Now, as you here in this room know very well, it's very rare that science finds the answer, capital A, right? You find an answer, and then a bunch of new questions pop up. Our next speaker is probably very familiar with this dynamic. Håvard E. Danielsen. He studies cancer genetics here at the University of Oslo and Oslo University Hospital. And in his project, Do More, they're trying to use AI to understand how different tumors develop differently, which means they might be treated differently and maybe stopped. Please give Håvard Danielsen a warm welcome.
Thank you. So, cancer patients may have the same diagnosis, receive exactly the same treatment, but have a drastically different outcome. They have different prognosis. Cancer diagnoses are in general correct in more than 95% of the cases, whereas current methods for prognosis are only correct in about 60% of the cases. For colorectal cancer, even less so. Histopathological grading, assessed by pathologists, is the main prognostic marker for cancer. Here are the histopathological grading results related to cancer-specific survival for 1,110 cancer patients in the QUASAR-2 trial. And what you see here is the 45 patients that the pathologists have classified as grade 1, meaning good prognosis. Another 168 patients have been classified as grade 3, meaning poor prognosis. But the difference between the two classifications are not really statistically significant, although the hazard ratio is about 1.7, which means that the patients in good prognosis have almost twice as high probability of surviving the disease. Unfortunately, as much as 846 patients, or 80%, are classified as grade 2, which means they have no clear prognosis. So it is clear that improved markers of prognosis is needed in order to stratify patients with early-stage cancer to refine selection of adjuvant therapy. In our Lighthouse project called Do More, we set out to develop new and better prognostic markers for prostate cancer, colorectal cancer, and lung cancer. And we have recently published our results on colorectal cancer in the Lancet. And I will briefly take you through this work. So the challenge was to find an algorithm or a method that could analyze routine histopathological specimens after surgery and obtain a prognostic marker that could be used to guide for further treatment of the patients. The tissue samples are prepared in a conventional way and scanned, and producing what we call whole slide images, such as the one you see behind me here. The resolution and quality of these images are as good as in conventional microscopy traditionally used by pathologists, but they are now being digital and hence applicable to AI. We have been using deep learning, which is a fantastic new method for image analysis, provided that you have large data which is representative for the real-world situation. So, through our clinical collaborators, we obtained multiple samples from more than 4,500 patients in 5 different cohorts with early-stage colorectal cancer. The experimental design had 4 phases, as it should have, which is training, tuning, testing, and final validation. I will talk about the training and the validation today. So the training material consisted of 828 patients with distinct prognosis. Here, this means that the good prognosis patients were disease-free for more than 6 years after surgery, and the poor prognosis patients died of the disease within 2.5 years after surgery. So we have a sort of a clear-cut thing to train the computers with. A total of 12 million tiles, image tiles, were used to train a total of 10 convolutional neural networks. And this is the sort of model or design that we used. So first we had to establish a convolutional network to identify the tumor in each of the whole slide images, as you can see here. This segmentation network was trained on images where the tumors have been outlined by the pathologists. That wasn't mine, that's good. So each whole slide was then tiled to a different resolution, to 2 different resolutions, with the highest resolution, which we call 40x, which is about 400 times magnification, was divided in around 6,500 image tiles. These tiles were then fed into our modified version of the MobileNet version 2 network. And before the tiles were pooled and classified in groups of 64 into a final score. The process was repeated 5 times for each resolution, giving on 1 average score for each resolution. In 88% of the cases, the 2 resolution ensemble scores gave the same prognostic classification, either poor or good prognosis for a given patient. So having gone successfully through the training, tuning, and testing, it was time to do a final independent validation of this new method. And that was done on the Quasar-2 cohort of stage 2 and 3 colorectal cancers that I introduced to you earlier in this presentation. And you might recall that this was the material where the pathologist had problems prognosticate more than 20% of the patients. Our DoMore version 1 deep learning method, which we have called histotyping, applied on tumor samples after surgery, classified 704 patients as good prognosis. And the follow-up of these patients have shown that almost 95% of them have survived for 5 years or longer after surgery. Another 270 patients were classified as poor prognosis, and only 68% of those survived for 5 years or longer. The hazard ratio is 3.84, that is almost 4 times higher than the good prognosis patients, and the separation between the peak is clearly highly significant. Only 136 patients, or 12%, were given different score in the 2 different resolution ensembles, and hence classified as uncertain prognosis. So to summarize, our new prognostic marker, histotyping, identified by our deep learning methods, find the tumor as well as the pathologists, and classify patients in prognostic groups with an accuracy which is not only much better than histopathology grading, as seen here, but actually also outperform all other prognostic markers in clinical use today. Only PN2, which is patients in stage 3 with metastasis in more than 4 of the lymph nodes, have a higher hazard ratio in the poor prognosis group than histotyping. This represents, of course, a very small fraction of the patient group, but even in this group, our marker was able to clearly distinguish between poor and good prognosis patients with a hazard ratio still about 3. So we have succeeded in making a new prognostic marker. What does that mean for the patients? Well, for the stage 2 colorectal cancer patients, It means that you can now more clearly identify those that actually need adjuvant treatment and treat those only. And the majority should be left after surgery. So we're trying to avoid undertreatment. For the stage 3 patients, the picture is a little bit more complicated, but the clinician should, together with the patient, use the prognostic score to decide whether the patient should actually have treatment, whether it should be a more careful single-agent treatment, or whether it should be a more radical addressed with the combined therapies and higher risk of toxicity and actually having a fatal outcome of the treatment. So this is where we are today. We're currently working on lung cancer and have similar results from the similar model. So this seems to be something that might make a real difference. I've been fortunate enough to lead this work, but obviously most of the work has been done by my 19-20 colleagues and co-authors, which you see here. So thank you for your attention.
Thank you so much, Håvard. It's very fascinating to see how quickly this can come into the everyday life of the patient. We'll be excited to follow this further.